Hello, I'm Mikhail Kosiborod, cardiologist at St. Luke's Mid-America Heart Institute in Kansas City, USA. And today we're talking about STEP HFpEF trials that we just presented at the European Society of Cardiology Congress in Amsterdam. So what was the rationale for STEP HFpEF? We know that patients with heart failure and preserved ejection fraction experience high burden of symptoms, physical limitations, and poor quality of life. And we also know that a large proportion of patients with HFpEF, nearly 80%, are living with overweight or obesity. As of right now, there are no approved treatments specifically targeting obesity in patients with HFpEF. However, there is a growing body of literature indicating that obesity and visceral adiposity may, in fact, be not just coexisting conditions or comorbidities, but key drivers in the development and progression of HFpEF. Accordingly, we tested the hypothesis whether semaglutide 2.4 milligrams once weekly, a potent GLP-1 receptor agonist that is known to produce significant weight loss in individuals with overweight or obesity, could provide heart failure benefits, specifically improved symptoms, physical limitations, and quality of life, as well as exercise function in patients with HFpEF and obesity. In STEP HFpEF trial, we randomized 529 patients that had known diagnosis of HFpEF, BMI of 30 and above, and met additional criteria such as elevated left ventricular filling pressures, elevated natriuretic peptides, and structural echo abnormalities or recent heart failure hospitalization within the previous 12 months, in addition to requirement for diuretic therapy or structural echo abnormalities, to either semaglutide 2.4 milligrams once weekly or placebo, and treated them for 52 weeks. What were the main findings? Semaglutide significantly improved symptoms, physical limitations that are related to heart failure in this patient population as compared with placebo. The treatment difference was about 8 points in favor of semaglutide. That was highly statistically significant, with a p-value of less than 0.001. Not surprisingly, patients treated with semaglutide also experienced greater weight loss, with a treatment difference of about 10.7% in favor of semaglutide, also highly significant. In terms of secondary endpoints, we observed that semaglutide significantly improved 6-minute walking distance. It also significantly reduced inflammation. And for one of the secondary endpoints, called the hierarchical composite, which was comprised of clinical events such as death from any cause, heart failure hospitalizations or urgent visits, and thresholds of change in KCCQ clinical summary score and 6-minute walking distance, we saw that semaglutide was also superior to placebo, with significantly more wins than placebo in this analysis that we call win ratio. That was also quite favorable for semaglutide and also highly statistically significant. There were a few additional secondary and exploratory endpoints. I will point out just a couple that I think will be of interest. Semaglutide significantly reduced N-terminal proBNP as compared with placebo, a biomarker of congestion. In addition, we looked at clinical events such as heart failure hospitalizations and urgent visits that were prospectively adjudicated. The STEP HFpEF trial was not powered for those events, but with that acknowledged, out of the 13 events that occurred in the trial, 12 occurred in the placebo group and only 1 in semaglutide group. Finally, semaglutide was well tolerated, and there were just half as many serious adverse events in patients treated with semaglutide as in patients that received placebo. So in summary, in the STEP HFpEF trial, semaglutide significantly improved heart failure-related symptoms and physical limitations, reduced inflammation, and resulted in greater weight loss than placebo. The magnitude of these benefits was large. They were clinically meaningful and highly statistically significant. Semaglutide also had favorable effects on markers of congestion, such as NT-proBNP. And while the number of clinical events, including heart failure hospitalizations and urgent visits, was small, there were fewer of them in patients treated with semaglutide than those treated with placebo. And finally, there were fewer serious adverse events with semaglutide versus placebo. Collectively, these findings indicate that semaglutide 2.4 milligrams once weekly is a valuable novel treatment strategy in patients with HFpEF and obesity. And I think the trial also confirms the hypothesis that directly targeting obesity is a key treatment strategy in patients with heart failure and preserved ejection fraction. There are additional trials currently ongoing that will have their results available in the near future. The first of these is STEP HFpEF diabetes trial. We're hoping to have the results available in early 2024. That trial is designed in a very similar way as STEP HFpEF, except it specifically focuses on patients with HFpEF, obesity, and type 2 diabetes. There is also a trial called SUMMIT, which is testing tirzepatide, a dual GLP-1 GIP agonist, in patients with HFpEF and obesity, and we're hoping to see the result of that trial in the near future as well.